the industry. So first, let's kick it off. It's my honor to introduce Dr. Mark Blatt. Dr. Blatt is the Worldwide Medical Director at Intel. In this role, he concentrates on how health information technology infrastructure can enable providers to deliver cost-effective, quality care to all citizens. As the worldwide spokesman for Intel, Dr. Blatt has spoken to over 50 events over the last 2 years on topics like integrated care delivery, mobile point care, and secure computing. Please welcome Dr. Blatt.
Absolute pleasure to be talking to you all. Can you hear me all right here? And then I'm going to just yell and stand here. That works for me. I really want to talk to you about something that's a passion to me, collaboration and collaborative care that actually empowers patients. I'm a family doc by training. I practiced in a small town in Connecticut. I'm going to start with a story about how I left practice and came to IT. It's the mid-90s. I'm on call on a 3-day holiday weekend during the summer for 12 other primary care docs. Now, if any of you are docs, you know this is going to be a bad weekend. It was. If you're moms, you know your kids get sick at about 5 o'clock on the holiday weekend as soon as the office closes. If you're kind enough, you wait till Saturday morning before you call me. Starting Saturday morning about 7 a.m., the calls start rolling in. I'm sitting there with a headset on, 3x5 cards, taking notes like mad. We don't have an EMR. We got a phone. Probably by 1 o'clock, I've gotten a couple of hundred phone calls. It's Saturday morning, holiday weekend. I can't send them all to the walk-in center or the office. I've got to actually do something to try to treat what I can. I realized I had actually diagnosed and treated, I don't know, 70, 75% of the people who called me, okay? Now, there were only 2 problems really with this business model. Now, it was great for the patients. No patient actually said, Dr. Blatt, I don't trust you on the phone. I need to drive around, spend $100, wait 4 hours and see you. They all took my advice. So there's so much for the doctor-patient relationship. Think about that for a moment. All right. What the patient wanted from me was convenient care and a response to their problem immediately. And that's what I offered. Now, from my point of view, the only real problem was it was free, and it might have been illegal. Now, I'm not sure. Aside from free and illegal, it seems like a good idea. All right. Monday morning, all those calls get intercepted by various secretaries. They become billable events. You take a half a day off from work, you pay me $100, and we got the same outcome. I felt like a shaman. What the heck was I doing in the office? So that began this journey and this drinking of telemedicine. Okay? How can I take care and reduce it? So here's kind of an Intel call to action. You heard of Moore's Law. All right? The fundamental problem with healthcare that we face in America right now is we are producing a product that is unaffordable. Think about healthcare as a product. None of you, I don't care how wealthy you are, could afford healthcare in this country. Your state can't afford it. The federal government can't afford it. My company can't afford it. The product we're producing is unaffordable. Okay? We're consuming 18% of GDP. We're crying and dying, and we're demanding a raise. Give me a break. We're IT. We can solve that problem. I want you guys to keep in mind some interesting bogeys. Tell me how you're going to double the volume of patients that move through the system and cut the cost of every interaction in half. Moore's Law for healthcare. Double the volume, cut the cost in half. I ain't going to ask you to do it every 18 months. Do it once in a decade and I'll be happy. I want to start to give you some ideas about how we can actually hit that bogey. How could I, as a primary care doc, care for 300 people? Think of my Saturday morning. I did that, and I took care of 200 people, more people than I took care of in a week in 6 hours. And I did it in 90-second bites, essentially for 0 cost. So let's talk about collaboration. And to do that, I'm going to start by playing a video for you, about 2 minutes, which talks about 2 workflows that make absolutely no sense unless we're actually thinking about my Saturday morning. How to avoid a readmission to the hospital, and how to avoid a transport to the emergency room if it's unnecessary, how to treat in place. Those things are going to be important. Already we know about avoided readmissions. We're there, we're getting the penalties, we're working on it, we're actually moving the dial. The next one you're going to hear about is avoided ED trips. By various estimates, 80% of people who end up in the emergency room, it's unnecessary. Easily 50%. Truven Health came out with a study 2 months ago, said 79%. That's a blow-away number. Take a look at this video and see if it stimulates some of your interest.
Secure mobile computing has already had a profound impact on medical care, at home, in medical transit, and in the hospital. Now, by enabling rich, multi-way video collaboration, the latest high-performance, ultra-mobile systems can help further improve medical outcomes, reduce hospital stays, admissions, and readmissions, simplify patient transfers, and greatly improve the effectiveness of care providers. Let's take a look at two areas where rich, real-time collaboration could make a big difference, avoiding unnecessary trips to the hospital and avoiding a patient readmission. Imagine a boy who was recently treated for pneumonia begins having an asthma attack. His mother calls for an ambulance. Using an ultrabook, the EMT immediately places a call to the child's physician, enabling her to see the child via video. While the doctor begins pulling up the boy's meds list, she asks the EMT to have the child breathe into a spirometer, the results of which are also streamed to the doctor's ultrabook in real time. The doctor determines the attack isn't severe and realizes one of the child's meds may need to be adjusted. She tells the EMT to let the child use his inhaler and makes an immediate change to the child's script. She then asks the EMT to monitor the patient for 20 minutes, repeat the tests, and call her back. In this instance, real-time video collaboration and concurrent streaming of medical data delivered far greater insight into the patient's condition in far less time, avoiding a potentially unnecessary and costly ER trip and subsequent hospital admission. Now imagine an elderly patient being discharged with an acute condition after a brief hospital stay. To ensure optimal at-home treatment and put the patient at ease, the discharge nurse sets up a video conference with the woman's nurse practitioner, her son, and the home care nurse assigned to her case. In just a few minutes, all parties are completely up to speed on her history and condition, including detailed imaging results, as well as her ongoing treatment, her required appointments, and any warning signs and symptoms. The result? The patient, her family, and clinicians are much more comfortable with her returning home. In this case, real-time video collaboration and multimedia data sharing greatly increased the understanding and comfort level of all parties involved, helping to potentially avoid an unnecessary and costly hospital readmission. These are just a few.
I'm going to end it there. So basically, two technologies that we couldn't do 3 years ago are now becoming commonplace. Real-time video communication, which is kind of a Jetsons dream. Now, how many of you Skype? Well, I bet half of the audience probably. And your grandparents are Skyping with your grandkids, and it's crossing generations. It's becoming easy to set up an inexpensive real-time video conference. You got a smartphone in your hand, you have the answer in your hand to do video. And now I can show you how you can do concurrent streaming of medical data at the same time. So what I want you to start to imagine is, how do I actually collaborate? How do I get actors in multiple locations, in multiple venues, with multiple tasks across the firewall to actually share data, collaborate, and get a different outcome? My Saturday morning on steroids. I want to blow away the physical plant and virtualize what I can. Now, I can't do 100%, but I can darn do a lot. And I'll do more going forward. Patient-centered medical home, you've heard about it. This is the NCQA scoring criteria for patient-centered medical home. It's 100 points, and it talks about collaboration. By the way, NCQA is going to revise this by March of next year to come out with a more advanced set of criteria around IT. It's 9 different domains. And what's most interesting is, you can't see it too good, but all right. What's most interesting is this is the standard of care, and this is what we teach docs in school and nurses in school. It's worth 20 points. I expect you to follow evidence-based medicine, do a diagnosis and get it right. I expect you to do that day in and day out, 100% of the time, never get it wrong. That's your baseline for coming to me. That's 20 points. The other 80 points are around collaboration with the system. And if you're not collaborating, you're becoming a cost center. I don't care if you're a primary doc or a neurosurgeon. I need you to start to have 24/7 communication with the patient. Maybe not you personally, but your organization or your system. I need you tracking results, tracking referrals, self-educating the patient so they don't have to come in and even see you. Again, workflows that make no sense if we're under fee-for-service. But we're busted, we can't afford it, it's a bubble, we have to figure out how to reduce costs, not just a touch, but a lot. This is going to be painful. Because the doc looks at me and says, well, I didn't go to medical school to be a paper pusher. I go, yes, you did. You know, if you just sit in your office and wait for sick people to show up, it's a 19th century business model. And I can show you example after example where doctors are going broke, and that's why they're crying and dying and want a raise. 18% of GDP ain't enough. I need more. It isn't going to work. Tell me how you exist on a 25% fee cut or a 50% fee cut without cutting your salary in half. That's what I want you to start thinking about. So, here's one example from the American Academy of Family Physicians about avoided readmissions. 09 data. If I could actually have a patient-centered medical home, 4% of my patients end up in the emergency room getting care. Without that, 21% do. Whoa. I could probably fund most of my deficit on that delta by keeping people out of the ED. That's going to be the next really big thing you're going to hear about. And unfortunately, that means you have to collaborate. Let me go through this, and let me talk about the IT infrastructure. I talk about 4 things you have to do right to make this happen. You got to gather data and digitize it. That's meaningful use part 1. You're doing that. You got to figure out how to share the data. That's meaningful use part 2. We're working on it. You got to go mobile because you got to give the information to whatever provider is wherever they are, and then you got to give it back to the patient. And I'll show you some quick evidence on what that matters. The more data you gather, the more you can share, the more you can mobilize. You create this virtuous cycle of data. And unfortunately for that guy who tells me he's not a paper pusher, it's actually about the data. 80% of the care is about the data and moving it in the right direction. We know this in every other industry. That's how we got dramatic productivity changes in transportation, travel, healthcare, financial services. It's coming to healthcare. And when I say collaborate, these are the actors and the venues I want to collaborate with. Okay? Not just primary care, road care, and teleradiology. That's a good start. That's cool. I like it. But if you want to avoid bringing people to the emergency room, who should you be talking to? How about these guys in the little red truck? They bring about 1/3 of the people to the emergency room. 2/3 are walk-ins. I get it. That's going to be harder. But about 1/3 of them are there. Now, this isn't a new idea, communicating with the ambulance. Anybody remember Rampart? You know? Come on, guys. This is a 1960s television show. And they were doing it back then. Is it standard kit for you to communicate bidirectionally with every ambulance that comes in and start treatment coming in? No. That's what we need to start thinking about. How do I do that? How do I leverage my community nurse, my home care nurse? It's not supposed to be a separate data stream and they never talk to you. All right. So here's a sign-on. It looks like your screen. But what I'm going to do is I'm going to actually launch a Windows 8 demo here. And I'm picking Windows 8 specifically because I can open multiple windows and do multiple things. So here's your initial splash screen. Here's my faking, the 2-factor, 3-factor authentication. I can use visual, I can use voice. And I can bring up a demo, and here's the demo in the corner on the side, a live tile changing. It's communicating with the underlying app underneath, which I made up called Mobile Point of Care. And I get a splash screen that comes on, which is this. And then I say, telemetry. And up comes telemetry. And then I say, back. Back. Good boy. All right. Then I say, DICOM. Now I split the screen, and I'm bringing in from 2 different places. I'm bringing in from a vendor-neutral archive of your choice, DICOM images stored anywhere you want, and maybe even including genomic profiles going forward. Okay? And I'm bringing in telemetry. What can you do with these side by side? That becomes pretty interesting. Back. EMR. Now I open it up 4 different ways. EMR. Things listening all the time. The microphone array on this is sensitive enough that I can do this without a headset in a moderately noisy environment. About a year from now, I'll be able to do this in a very noisy environment, and it'll find my voice. This is getting better and better as we go forward. And for those of you of interest, we're using Nuance to actually make this go forward and use the voice command and control. And we announced the other day at IDF that all Ultrabooks going forward are going to ship with embedded Nuance for command and control of the platforms. Okay, so I'm running OpenEMR here, which if you're from Africa, you understand why I picked OpenEMR, because I don't have 100 million for Epic. All right, back. Okay, sync. Sounds a lot like Link, doesn't it? Well, okay, it looks a lot like Link, but I'm not paying Microsoft either. All right. So now I'm going to just double tap and I'm going to expand link. And now I've got a two-way video conference going. I can see the EMR. I can see I can see all the different things. I've called the patient at home or the daughter of the patient at home and said, I understand you were in when I was gone. What do you want to know? Well, the mom's having an operation tomorrow. I had 3 questions and I waited all day and you didn't show up. Okay, now I'm here. Let's talk. Okay, now you have a conversation. She asks a question. You say, well, let me bring in my colleague here, and we're going to have a 3-way conversation. So now I can actually open up a multimedia 3-way conversation and have that conversation with the patient in real time. And if you haven't built an effective exchange in your Planet, you can actually use this to control data. Okay, so we're done with that. And I'll see if I can go back here, and I'll finish real quickly. I want to show you some stuff on patient empowerment. Take a second to recognize it again. It'll figure it out. So that video vision I showed you before with the real-time communication in the ambulance, that's actually true right now. It's real. We're actually doing this at Valley Health in the Shenandoah Valley, and we're actually bringing real-time 12-lead EKGs by putting a local cloud up in the ambulance, and we're sending the data back through the cloud, not to an access point, because the cloud is much more reliable. I can attach an iPhone, an iPad, whatever device you wanted, whatever sensor equipment you develop, I can now attach it to the cloud, so I'm ready for the future. And I can attach dozens of access points to it, right? At home, if you take a commercial router, an off-the-shelf router in your house, it works really cool. Now your TV wants to talk to it, it gets a little flaky with Netflix. Now all of a sudden your kids come home, they got their eye. Once you get 4 or 5 things, the routers start to have problems. That's why we put up the cloud. It's robust, it's available, it's 100% reliable. EMS doesn't care about it, and I can send equipment back. And the real key is the clinical change in workflow and outcome. By getting a 12-lead granular EKG, I can start treating the patients in the ambulance for STEMI, acute MI. I can start clot busters, I can start treating them. I take door-to-balloon time. I took door-to-EKG and made it negative, and I took door-to-balloon time down about 35%. That's when I get them into the cath lab, dilate their, boom. And I actually get more patients with normal ejection fractions, over 50%, means a normal heart. Time and heart are the same thing in this thing. So now let's just jump into collaborative workflow and talk about patients. One of the things with patients is empowering them with data. So I'm going to give you a radical thought. Why can't they read your chart? Why can't they read all your notes? How many of you doctors here? You like this idea, the patient's reading all your notes? Maybe you're a little confused. The patient won't understand it. They're going to kill themselves, jump in the lake, they're going to call me. It's just not going to work. You're going to throw every piece of FUD at me you can. And it's anecdote. And by the way, the plural of anecdote isn't data. It's anecdote, okay? There's a study in this semi-reputable journal called Annals of Internal Medicine. All right, that's a pretty good study. Not even a year old, from some place called Beth Israel and Geisinger and Harborview. 100 docs, thousands of patients. And what they did after the visit is they sent them a URL and said, here's the note, read it. Halfway between the visits, they sent them a reminder, said, read it. Just before the visit, they sent them a third one, said, read it. Half the patients opened one note. And you're right, somewhere around 5% of the patients got nervous and scared. There were some issues around privacy. We can work those out. 80% of the patients responded by saying, it increased my sense of well-being and participation. And then the most unexpected result is about 70% improved med compliance. Huh? Why? Well, maybe, I don't know, maybe Dr. Blatt wrote a note saying you're a 60-year-old hypertensive, non-compliant diabetic with acute risk for heart disease, schedule emergency stress test. You read that and you go, oh my God, he thinks I'm going to die. Maybe when you read it, it wasn't so bad, but when you showed it to your wife, she said, you're taking your pills. I don't know. But it changed. This wasn't, RFID dissolving pills, and this was opening the chart to the patient. And look at the results. So let's change to Kaiser, an organization that's represented here tonight. We can talk about this. In Kaiser, Hawaii, they had some problems with transportation. Another little journal, Health Affairs. Okay? So Kaiser opens up their medical records with my charts in 04 because they got them system-wide now. And look what happens to office visits. And look what happens to scheduled telephone calls. And you might say, well, that's simple problems. Well, it happened with the specialist as well as the primary care docs. Their visits went down dramatically, such that by the end of 07, about a third of what Kaiser was doing in Hawaii was now virtual. Most of it was scheduled visits, but you start to see IM and chat creeping in there. Anecdotally, what we hear by the end of 012
is about half of the visits are virtual. Hawaii, just the Hawaii division. About half are virtual. IM and chat scheduled visits, and now about 20 or so pilots around video conferencing and real-time communication. The cost of production of those non-face-to-face visits, compare them to your cost of face-to-face, where they're about to get blown out of the water. I can produce those visits for probably less than half the cost and maybe as much as 25%. It's my Saturday morning. It's now legal, and it's happening everywhere. Worldwide telemedicine is skyrocketing across all chronic disease disciplines. Here's a little booth from a company in innovation called HealthSpot. 35 square feet, I can drop it anywhere I want, and I can create a virtual visit with different devices, scheduling system, $12 MA to help you through the booth. It can show up anywhere there's an office, and I can do this a whole lot cheaper. And now I can actually say, what if I charge you 50 bucks, 40 bucks for a visit? The heck with the CPT code, the heck with ICD, the heck with insurance. Direct to consumer, would you pay the 40 bucks? I love it because there's 4 motherboards in that thing. Last thought. Boston Medical Center said, what if I took that virtual sign out that I was thinking about between the 2 nurses and made a nurse on one side an avatar? A racially, culturally specific avatar to talk to the patients, to do sign out. Structured communication, pretty easy to do. Here's your directions and information. So now for you supervisors out there, the question is, how many avatars can you supervise? Times they are changing. So this begs the question, what is the value of an EMR? It is not transactional. It is not to increase throughput so I can upcode and get more payments. It's so I can have a foundational platform for what I did on Saturday morning so I can virtualize care. So I can keep you out of the hospital, out of the ED, out of the doctor's visits, and deliver care for 20 cents, 30 cents on the dollar. Moore's Law on steroids. That's the value of an EMR. Empowering, educating patients, and using all the different mechanisms that we use in the rest of our life for this. So, collaborative workflows, patient empowerment, and maybe the idea of visiting a doctor is about to change. Thanks, guys.